Hi there, thanks for tuning in. I'm Ryan Madnick. I'm going to give you some highlights from what I saw today at DDW. This was day 2, Sunday. I mainly went to some esophageal sessions, and some very good information really came out of today's poster sessions and esophageal sessions. So let's get right to it. There were a couple abstracts in the pharmacologic therapy for GERD that I thought were quite interesting, mainly from a proof of principle standpoint. Unfortunately, I don't think they're going to lead to very rapid development of drugs, but they do give us some hope for development of new compounds that might help in the treatment of refractory chest pain, refractory heartburn. So the first abstract was abstract number 315, presented by Dr. Karup. This was a compound called AZD1386. It's an antagonist for a molecule called TRPV1. It's a receptor that has to do with hyperalgesia. So this was actually getting at treating esophageal hyperalgesia in reflux patients. They used healthy volunteers. It was a proof of mechanism study, and they did find that the drug worked in decreasing esophageal hyperalgesia. Unfortunately, drug development was stopped. We don't exactly know why, but the company did stop drug development. The second abstract that was presented was abstract number 318 by Dr. Beckstans. This was an antagonist against mGlu-R5, another receptor that is expressed in the vagal afferent nerves and modulates mechanosensory input. This was compound AZD2066, and they found that it decreased transient lower esophageal sphincter relaxations by a 27% at 13 milligram dose in the 3-hour postprandial period. I believe he did say that this drug has also been stopped in development. The next study that was a little bit controversial, did have a lot of comments to it, was study number 319 by Dr. Mir Bagheri, looking at a 6-arm study. They called it a 6-arm study. It really wasn't 6 arms, but fluoxetine, which is an SSRI, compared with omeprazole and placebo in pH positive and pH negative groups of patients with non-erosive reflux disease. What they found was there was really no difference in improvement of symptoms between omeprazole and fluoxetine. Both controlled symptoms well compared to placebo, even in the pH positive non-erosive group. However, there were a lot of problems, I think, with their definition of non-erosive reflux disease. They used a dyspepsia marker to define gastroesophageal reflux disease. I think there's a lot of work that has to be done to really flesh out whether or not this is going to get into the literature. But it does give us hope that at least some of the SSRIs may show promise in treating some of the upper GI symptomatology. The next abstract I'm going to talk about was abstract number 497, and really goes with another abstract that was presented in poster form, abstract number 1041, poster number 1041 today. Both were out of the same group in Northwestern, Dr. Karillis and Dr. Pandolfino's group, and they looked at a very important question. And their question was, in patients with negative pH or in pH impedance, 2 different studies, pH studies with Bravo, number 1041, or pH impedance studies at the abstract number 497, what percent of patients with negative studies continued on their PPI, even though they had a negative study? 40% of Bravo negative patients stayed on their PPI, and between 45 and 82% of their pH impedance negative patients stayed on their PPI. 45% if they were tested off therapy, 82% if they were tested on therapy. They discussed some of the potential reasons, some of the reasons being that their doctors never told them to stop, or that maybe they were taking it for some other reason. But this is an area that may very well need some increased investigation as to why patients remain on their PPIs despite a negative study. My own philosophy on this is that that's a good reason not to test them off therapy, because many patients, as this group has shown, aren't going to come off therapy anyway, even if we tell them they have a negative study. So I test them on therapy, but that's a discussion for another talk. In the next few moments, I'm going to go over a few interesting posters I found in the esophageal world. Poster number 1468 was out of the Dartmouth group. Their question was, in patients with Barrett's esophagus, what is the prevalence of subsquamous intestinal metaplasia, otherwise known as buried glands, in the squamous mucosa immediately above the squamocolumnar junction? Not in patients who were treated with radiofrequency ablation. This is in the native state. They found 50 to 90% of Barrett's patients had subsquamous intestinal metaplasia within 1 centimeter of the squamocolumnar junction. And that's important because if we're going to look at subsquamous intestinal metaplasia as an outcome, we have to know what the baseline rate is. So, very important study. The next poster was poster number 1490, which was a sub-analysis of a large study of a drug called lisogabaran, otherwise known as AZD 3355. This sub-analysis asked the question, in patients with partial response to PPIs, what is the prevalence of mucosal damage? And what they found was 20 to 30% of patients who were considered partial responders by their entry criteria had mucosal breaks at baseline. Again, indicating that they may, just because they're partial responders doesn't mean that they're going to have healed mucosa. Two surgical studies, which I found interesting, next to each other, 1622 and 1623. 1622 looked at an interesting question that really doesn't have much to do with the esophagus, with the exception of it has to do with hiatal hernias, but esophagologists don't often see this group. This was in patients with large paraesophageal hernias that have anemia. What percent of these patients have improvement in their anemia after repair of the hiatal hernia? 50 to 88% improved their anemia. 50% if they had no erosions, no Cameron erosions, and 88% improved their anemia if they had Cameron erosions. There was no control group, just a case series, but again, gives us good rationale for sending patients with large paraesophageal hernias and refractory iron deficiency anemia to the surgeons for repair. This is large paraesophageal hernias, not the small ones. 1623, the study right next to it, was sort of a proof of principle study in patients on high-resolution manometry who were found to have a hypertensive upper esophageal sphincter. After surgery for gastroesophageal reflux disease, the mean pressure dropped from 154 to 122 at the upper esophageal sphincter, potentially indicating that the hypertension in the sphincter was related to underlying gastroesophageal reflux disease. One of the possibilities is that it's actually a reflex because of the reflux. It's a protective reflex to protect the airways. The last poster that I'm going to talk about is poster number 2024, poster that's near and dear to my heart. They're talking about chronic coughers. These are irrespective of whether or not they have to do with reflux. We see a lot of these in esophageal practice. So what they looked at was chronic coughers versus healthy volunteers. They stimulated pharynx and the esophagus. What they found was in healthy volunteers there was very little cough that was induced, but in chronic coughers they could actually induce cough by stimulating. And the cough was significantly more prominent when they stimulated the esophagus compared to when they stimulated the pharynx. Interesting findings. She told me, the investigator there told me, Dr. Young told me that she uses pregabalin to help treat these patients. I particularly use gabapentin to help treat these patients. That's unpublished data. I'm going to be looking at some of the data right now. That's completely off-label use. If you don't have experience with it, then don't use it. But if you have any questions about that, certainly drop me a line. I'd be happy to give you my experience. Again, I'm going to be looking at that data shortly. But I think this gives us some feedback that potentially chronic coughers their chronic cough may be related to peripheral or central abnormalities in the neurologic system. So I think we have a lot to look forward to in terms of therapy for cough. So an exciting day in the world of esophageal disease. I particularly focused on the bland gastroesophageal reflux disease, not so much the pre-neoplastic or the neoplastic with Barrett's, etc. So, but maybe we'll see what happens tomorrow. I'm not exactly sure what sessions I'm going to go to, The plenary sessions are tomorrow, but stay tuned. Stay on the stream. We'll see you use hashtag DDW11. Follow the stream and follow my blog at ryanmadnickmd.wordpress.com.